Next up is the TASER protocol. Tasers being deployed more and more and more throughout the state, and there has been not really any clear guideline on what EMS involvement should be regarding taser management. After doing a really thorough review of the literature and reading the position statements of several of the emergency medicine organizations relative to patients that have been tased, in most circumstances, there's not any good reason that the patient needs to have medical evaluation after they've been tased. They simply need to have their taser barbs removed, maybe a Band-Aid applied to the wound if it's bleeding. No further care is necessary. So what we really feel is that in most circumstances, the barbs could be removed by law enforcement without any involvement of EMS. However, should the probe be embedded in eye, genitals, bone, the patient has a seizure after they've been tased, there's excessive bleeding from the probe site after removal. Obviously, if they have some sort of arrhythmia or cardiac arrest, any complaints of chest pain, respiratory distress, or altered mental status after being tased, they should receive medical evaluation. There is no data at all about what to do with a patient that has been tased who is pregnant, so I would probably advise that they also be transported for some evaluation. In the event, however, that you see a patient and provide care for a patient that has been tased and they do not want transport, just like any other refusal of care, you should obtain a refusal of care and have them sign it.
Vascular access via central catheters there's no change there. And then lastly, on our procedures, we have a ventilator procedure. And this is for the pre-hospital environment. We're not talking about in a facility transfer here. We're talking about pre-hospitally, and pretty much the RSI folks that have elected to purchase some ventilators to give them some guidance on their ventilator settings.
Could also potentially use for cardiac arrest patients as well. Mm-hmm. Some services have a ventilator. So this protocol is really done just to, it was really put together to guide you into how to set your initial ventilator settings up. If you have a device and you're familiar with it and you put the settings on, it could free up some hands and allow you to do other things instead of bag valve ventilating, and set a consistent rate for some of these patients to avoid hyperventilation.
Okay. And that completes the procedure section.
All right.
Next is prerequisites. Hang in there, folks. We're almost done.
Are you talking to us or the audience?
I'm talking to the audience.
No.
So our next section is a prerequisite section. We have 4 prerequisite protocols. The first is the community paramedicine protocol. This is a new protocol, and this protocol was written to help for communities that have identified gaps in health care where the EMS may be used to help fill those gaps. There's a regular group of people that meet monthly, and if you're interested in becoming part of this, the best advice is to give me a call and I will help you get established with this.
Immunization protocol, there have been no changes.
No changes to that.
I would like to recommend that everyone get their flu shot this year. Public health announcement.
Interfacility transfers. Changes there is at the PIF level. One of the things over the past 2 years with the introduction of PIF, probably the most frequent call is questions on patients that are on ventilators. And so we've tried to clarify that. First, for our patients that are long-term vented patients, these are stable patients. They've been on vents for months, years, and it's okay to transfer those patients from one facility to the other, from home to the hospital, from the hospital to the home. without a second attendant in the back for those. And then for your unstable patients, we've tried to clarify the vent settings at the PIF level as those that are assist control or the SIMV that are non-complex settings. But these patients will have to have the second provider in the back.
The only thing I would clarify in the chronic vented patients, that those are provided that they're being transported on their ventilator and they're not being seen for a primary
Right.
respiratory chief complaint.
Right. So. And the last prerequisite protocol is the RSI protocol. And
So a couple of
about that.
changes on this, or really additions. One, in the pre-oxygenation, we're learning about the concept of apneic oxygenation, and it's a little different than we've been taught in the past. So if you're pre-oxygenating patients, 100% via non-rebreather face mask, turn the dial as far as it'll go to hyperoxygenate them, and also apply nasal cannula to these patients as well. You could put it on 15 liters per minute, and when you sedate them, keep that nasal cannula on. When you sedate and paralyze them, keep that nasal cannula on throughout the procedure, and it's been shown that this actually extends and keeps your oxygen saturation at a higher level than if you didn't have it on. So it's okay to put a nasal cannula, 15 liters, where you sedate and paralyze these patients, keep it on throughout the procedure, and then remove it once your endotracheal tube is secure, and that'll keep your oxygen saturation up for longer periods of time. The other thing in this protocol that is a little different, due to our medication shortages, we added some medications. If there's a shortage of etomidate right now for some of our systems, one thing we had added already through a bulletin was the option of midazolam. Not the best medication for this, but it's an option if you need it. And the reason for patients in shock is it can cause hypotension. The other thing that we're looking to add is, as an option if etomidate is unavailable, as a second option would be ketamine. Accepted medication in RSI intubation. The only issue is right now it hasn't been brought to the Board of Pharmacy, so pending approval to the Board of Pharmacy, we'll also have ketamine as an option if etomidate is not available.
Correct. And another caveat, please make sure after you perform RSI, confirm tube placement and make sure your patient is sedated afterwards. We have seen a few errors of people that might get a paralytic and then not get sedated, so they're awake but yet paralyzed and being ventilated. Please make sure you provide them with adequate sedation.
And that ends the prerequisite section. All right, now we're moving into what we're calling our policies in the protocols. The first one is abuse and neglect of child, elder, incapacitated adults, or other vulnerable individuals. And there's no changes from our last edition. Air medical transport, there's some small changes in here. We've included the STEMI and stroke in here. We've changed the transport from just a level 1 to a level 1 or level 2 trauma hospital for our trauma patients. Also included a PCI center and stroke centers. Under the clinical conditions for STEMI patients, if your 12 lead indicates a STEMI, then that is one of the indications for air medical transport if that's in your local guidelines. Additionally, for the stroke patients, if you have one or more signs from the stroke scale and the symptoms and signs have come along in the last 3 to 4.5 hours, again, according to your local stroke plan, you can initiate air medical transport.
Oh, hold on. Just sort of as a refresher, air medical transport not indicated for patients already in cardiac arrest. Also not indicated for contaminated patients until after decontamination has been completed.
Point. Bloodborne, airborne pathogens, no change there. Communication, there's no change. Communication failure, we did have a change in the reporting. So if you have failure with communications and you need to perform some procedure, You need to report that to your medical resource hospital and or your EMS hospital coordinator within 48 hours.
So if you, again, if you had to do something that you would typically contact medical control for, and you did it in the event of a communications failure, please report that to us. That's all.
The consent for treating a minor is not new. This was buried in the routine patient care, and we pulled it out and made it separate. So there's no change. Same with the crime scene preservation of evidence. DNR, we have a little bit of a change in there. If you want to turn to the next to the last page, you'll see there's a section called PULSed for provider orders of life-sustaining treatment. And in the back of the protocols in the appendices, you'll find a copy of the PULSE form. But in there's a section B in which a patient can check off what type of treatment they would want. The first box says full treatment, and if this box is checked off, then these patients want to be fully resuscitated. There's a full resuscitation on them. Limited intervention box, if that's checked, the maximum you want to do for airway interventions is a non-rebreather mask, CPAP, and suctioning. And for IV medications, you can utilize all of those that are appropriate. No electrical therapy on these. And then for the comfort care box, if that's checked, if you read it, it says they don't want to go to the hospital, so they probably should not even be calling 911, but they do. So if you get called and that box is checked off, your maximum interventions there is non-rebreather, suctioning, removing any airway obstructions, and then medications for comfort care or pain care only. And then you might see down in section C, there's an IV therapy for hydration and nutrition. That for EMS, you may start an IV for the purposes of comfort care or administering medications. So,
the only other thing I would add briefly in DNR, if you have a patient who has a DPOA, a durable power of attorney for healthcare, if they cannot locate the valid DNR or they want you to not resuscitate the patient, in those situations you can also call medical control for guidance. You may have to start CPR if until you sort it out, but it's okay to call medical control and discuss the case, because there are cases you may have very elderly. We've had cases, 98-year-old, 100-year-old patient in cardiac arrest, does not have a valid DNR, and there's a power of attorney there who's saying they should stop, they do not want to be resuscitated. You can use medical control for guidance in those situations as well.
The on-scene medical personnel has not changed.